Okay. Hello, everyone. It's great to be with you today. I'm so relaxed after Dr. Wong's talk. That's just amazing. And thanks to the organizers, to Mary Lou and everyone for inviting me today. We're going to be talking about a big topic today, social isolation and loneliness among older adults, and some work that we're doing at the Canadian Coalition for Seniors' Mental Health. I don't have anything to disclose. I've listed some sources of grants and research support there, mostly federal agencies and so on. And the learning objectives for this talk are that by the end of the presentation, you'll be aware of the association between loneliness and social isolation and poor health, as well as reduced lifespan, be able to describe the range of potential interventions by healthcare and social service providers to reduce loneliness and social isolation, and consider the potential benefits and challenges in developing clinical guidelines in this area. And so we'll go over kind of an overview of the topic, look at some international perspectives, and then I'll be describing this project where we are actively developing clinical guidelines right now, and some interventions to think about, and hopefully some reflection and discussion at the end. And I'm noting we started about 10 minutes late, so because I do need the full time today. So the Canadian Coalition for Seniors' Mental Health, in case you're not aware of us, we've been around for 20 years now, and we're linked to the Canadian Academy of Geriatric Psychiatry. And if you want to join, if you're interested in mental health of older adults, the website is up there, ccsmh.ca. It's free to join. You can become an affiliate, and then you'll get all of our materials. This is some of the recent work we've done, depression guidelines, substance use disorder guidelines, some e-learning on cannabis in older adults. You can get all this from our website. And currently, the red is the project I'm going to be talking about today, which is funded by an anonymous private foundation. It's the first time we've had that kind of funding. And also a big project funded by the Public Health Agency of Canada. So we're currently working on clinical guidelines for responsive behaviors, BPSD, also for anxiety disorders, as well as some new KT tools for our existing materials. So I think, we're all aware of the impact of COVID-19 and the pandemic on interactions, on the whole issue of social isolation. It's been a challenge for all of us. And one thing that I wanted you to do is just for a minute, just to reflect on these questions. So the first one is, have you personally experienced some degree of social or professional isolation during the pandemic? Yes or no? Have you felt lonely for significant periods during this time? Yes or no? And when doing a new assessment, if you're a clinician, how often do you ask patients specifically about loneliness? Always? Most of the time? Quite often or occasionally? And you'd be interested to know, I've asked this question a number of times to different groups using live polling, and I've been quite surprised by the very high number of people responding yes, including to question 2 about how lonely they've felt during this time. So there's no doubt that loneliness has more often been the purview of poets and songwriters and artists than health professionals. But we all have a deep emotional response to this feeling. And so here, you can see on the left is a painting by Kay Sage, who was an American surrealist painter. She was married to another painter called Yves Tanguay. But I think it really evokes a sense of isolation and loneliness. And she was someone who suffered from great depression after her husband died. On the right, you see the words from the Beatles, Lennon and McCartney, from Eleanor Rigby, all the lonely people, where do they all come from? And the sort of sad words around Eleanor Rigby, who died in a church and was buried along with her name, and nobody came. This is a different kind of feeling. This is from Green Day. And For me, this sort of evokes something different than the sadness of Eleanor Rigby. This is more a kind of an acceptance, even a degree of pride. This is who I am. This is the road that I know. So I don't know if you'd feel or agree with me, but it's definitely got a different feel to it. And there's a point here, and that is when we talk about social isolation and loneliness, there's always this assumption that, being socially isolated is a terrible thing. We've got to fix it right away. And I would say one take-home message today is let's not make assumptions. There are some people out there who are quite comfortable, actually, being relatively alone. Not everyone by any means, but we shouldn't make assumptions. That's my point. Each person is an individual. So Frieda Fromm-Reichmann was a German-American psychiatrist, and she noted a strange reluctance on the part of psychiatrists to seek scientific clarification of the subject of loneliness, and said that thus it comes about that loneliness is one of the least satisfactorily conceptualized psychological phenomena, not even mentioned in most psychiatric textbooks. And she goes on to say that it seems to be such a painful, frightening experience that people will do practically everything to avoid it. So a colleague of mine, Amy Friedman and Nicole, wrote that social isolation and loneliness in older adults is one of the new geriatric giants. It's such a huge issue. And certainly we're all aware of the fact that a huge number of people report themselves as being socially isolated or lonely or both. And then there's a lot of evidence that there's an association, again, it's an association between isolation and loneliness and health, and it's all on the negative side. So, on average, if you are isolated and or lonely, you have an increased risk of stroke, of coronary heart disease, of cancer mortality, dementia, certainly, of course, of depression, increased risk of functional decline, and even an increased risk of death over time. This is pretty concerning. So Julianne Holt-Lundstad, who's one of the gurus in this area and colleague, wrote very recently in the New England Journal of Medicine that social isolation and loneliness are rarely listed on death certificates, yet they may contribute to the excess deaths from all causes observed during the pandemic. Although the health sector cannot solve this problem alone, the medical community does need to respond. Clinicians will require adequate training, resources, and support to integrate screening, interventions, and referrals for social isolation and loneliness into their existing responsibilities. Patients' lives may hang in the balance. Well, that's a very strong statement, isn't it? It suggests that what's been conceptualized as just a social issue is now also a health issue, medical issue. We certainly know about the association between loneliness and mental health. Social relationships are crucial for most people to emotional, psychological, and physical well-being. There's a powerful connection to depression, a reciprocal relationship. And then an interesting quote from the Harvard Study of Adult Development. Close relationships, more than money or fame, are what keep people happy throughout their lives. Those ties protect people from life's discontents, help to delay mental and physical decline, and are better predictors of long and happy lives than social class, IQ, or even genes. And this study sort of proved this right across different groups of individuals from different sectors of society. And of course, there is this is Canadian data on the relationship between mental health and loneliness. So if you're rarely or never lonely, you have a much higher report of people feeling excellent or good mental health. Former US Surgeon General Vivek Murthy said that we live in the most technologically connected age in the history of civilization, yet rates of loneliness have doubled since the 1980s. And this is data on, the increased use of various social media over the years, and dramatic increases, of course, in the use of Facebook and YouTube, WhatsApp, and so on. And so the question is this good or bad when it comes to connectivity? Because I think the young folks amongst us will say we are more connected, we are better connected than any group in history. And yet, is this true connection? Maybe it is. It's an interesting question. So in the United Kingdom, of course, they appointed a federal minister for loneliness. Kind of a remarkable response if you think about it. And they have this ongoing campaign called the Campaign to End Loneliness. It's been funded. It's been written about. There's lots of interesting material and literature published and grey literature. Lots to learn for us. And of course, we do not have a national campaign to end loneliness and social isolation. And I guess I'll throw out the question to you. Do you think we should? There are position statements from different organizations from around the world on this. There's a global initiative on loneliness and connection. There are some great publications in this area. So right in the middle is from our own National Institute on Aging. It's a great document on understanding social isolation and loneliness among older Canadians. Strongly recommend this. I've taken a few images from this report in this presentation. On the right is also a fantastic detailed report from the National Academies of Sciences, Engineering, and Medicine in the US on the opportunities for the healthcare system regarding this issue. And then a new publication on the left from Jesty and colleagues, American Psychiatric Association Press, a good book in this area. The World Health Organization has highlighted this as an issue in a separate document and noted this is really a global issue. It is important, though, for us to differentiate two overlapping concepts here. So social isolation is more objective. So it's a measurable deficiency in the number of social relationships that a person has. So it's an objective deficit. Whereas loneliness is much more subjective. It's an internal experience. It is an unpleasant sensation felt when a person's social relationships are lacking in quality or quantity compared to what they desire. So there's different ways of looking at social connection, structural, functional, quality. So you could look at the actual relationships that a person has, the number of connections, the amount of time they spend. You can look at it functionally in terms of support. Is there an element of support or perceived support in those relationships? But also the quality of the relationships. So as a psychiatrist, well, I think we all are aware that not all relationships are positive. So there are positive and negative aspects of social relationships, and we should never forget that. There are also different ways of thinking about loneliness, social, emotional, and a deeper kind of existential sense that in some ways we're all alone in the world. So this slide shows the overlap between social isolation and loneliness, but it does demonstrate that they don't totally overlap. So, some people who are very isolated are not lonely, and some people who are very lonely are not isolated, and there's different degrees of overlap. So it is important to recognize that. What about loneliness across the lifespan? Well, this is interesting, but there's a lot of conflicting data on this. So a meta-analysis recently found a U-shaped trajectory. So decreasing levels throughout childhood, and then stability, and then an increase in old age. Other studies have actually shown elevated levels in midlife. But either way, health issues are associated with loneliness across the entire lifespan. And so the bottom line is actually there are inconsistent findings. And an interesting study from the BBC, 46,000 people brought together through the BBC. And what they found was that at all ages, there was actually increased loneliness in countries that have greater individualism versus connectivism. And I was very excited by this paper, which came out recently. It looked like the prevalence of loneliness across 113 countries. But actually, more than anything else, it pointed out there were a lot of deficiencies in data. They did show a geographic pattern for loneliness, with Northern European countries showing lower levels of loneliness. Very surprising. And then this, which is not from that study, but from other data, this is mostly European countries. Quite interesting. This suggests that Mediterranean countries like Greece, Israel, and Italy had higher rates of reported loneliness among older adults than Northern and Central European countries or the US. And that's kind of surprising to me. I'm not sure what to make of that. And I wonder if it's because individuals from Mediterranean countries, I think, are often more open about their emotions and possibly even more connected to their emotions. But it's an interesting finding. There is more loneliness, higher levels of loneliness reported among marginalized communities. Certainly studies from the US show that. Immigrants. So very important for us to recognize that as well. So why is it that there's actually this strong association between social connection and health? There's a lot of work going on right now to try to figure this out. Could it be relationships between social connection and aspects of lifestyle, like physical activity and nutrition, etc.? Is it psychological factors that are connected to biomarkers? Could it be that people who are more socially isolated tend to be less likely to adhere to medical advice and treatment? A lot of studies right now are looking at things like inflammation and its association. So it's possible that there's a flow of different factors that contribute and that can actually lead to biological, physical changes in the body, which ultimately can lead to illness and death. So our project on creating clinical guidelines in this area, it's funded, as I say, by a private foundation. This foundation is very interested in this area and is very supportive. It's a 2-year project. It ends in March of next year. We believe that there's a strong opportunity for healthcare providers and social service providers to really make a difference. We, of course, start with a lit review, which I can tell you about. We have a great working group from across the country. We've completed a national survey of health and social service providers recently. And we're doing another survey soon on older adults themselves and caregivers. And ultimately, we will produce a guideline document and disseminate it with toolkits, et cetera. And we want to be part of the world that's raising awareness and strengthening networks. This is a list of people on our working group, really a fantastic group, interprofessional from across Canada, east to west. Great support staff as well. And, clinical guidelines can be helpful. Certainly our coalition believes so. We've produced quite a lot, but it's been said that clinical guidelines can improve the quality and consistency of care, improve healthcare outcomes, empower patients to make more informed healthcare choices, inform public policy, call attention to under-recognized health problems, prevention and interventions, as well as to neglected patient populations, identify research gaps. And, there's also the potential for clinical guidelines to do harm. I don't think that's often, but they can be utopian and advise clinicians to do things that are maybe excessive or unreasonable. But by and large, I think they do good. There's a whole process for creating guidelines. I won't go into it in detail at all, but ultimately it's, of course, looking at the evidence and trying to turn the evidence into good, useful recommendations that can be helpful for clinicians in making decisions. So we're doing our best to be evidence-based, although, as always, there are deficiencies, but we want a manageable stepped care approach to identifying and addressing this issue, broad range of approaches, guidance promoting wellness and reducing the risk as well, so some preventative approaches, and then targeted messaging, knowledge translation, and tools. So normally with guidelines, you start by reviewing existing clinical guidelines to learn from those and perhaps modify or further develop them. Currently, there aren't any existing clinical guidelines, probably because loneliness and isolation, it's not a diagnosis, right? Now, the NASM report has some recommendations. They don't call themselves guidelines, but they do have some recommendations, such as this one. They say that healthcare providers and practices should periodically perform an assessment using one or more validated tools to identify older adults experiencing social isolation and loneliness, and to initiate potential preventative interventions after having identified individuals at elevated risk. And then if you do identify people, you should discuss adverse health outcomes and then try to intervene, and a tailored approach. So, some very useful recommendations there. I'm sure our guidelines will reflect as well. We've done a review of the literature and promising practices. Celinda Horgan and Jeanette Prorak are consulting and helping us with this. We've looked at these 4 areas, so practice interventions, patient experience, promising practices, and screening and assessment tools. So looking at practice interventions, there's a whole variety that are listed here on the left. And so that's great because there's a lot of things that may help people. Question is, for whom? When do you offer one or other of these interventions? And that's a bit of an issue because the literature doesn't really tell us that. I've highlighted social prescribing. I know you had a session yesterday on this. It's certainly a very promising approach. It's gaining momentum, but it is only one type of intervention. So I think we should be careful and consider what's going on, what's contributing to the social isolation and loneliness, and take a biopsychosocial approach to trying to understand it. So, for example, if someone has a profound depression that's causing them to become more withdrawn and isolated, then social prescribing may help a bit, but you really want to treat the depression. Or if someone's agoraphobic and can't go out because they're agoraphobic, we better address that as a problem. So the review so far of the literature has suggested that there's no conclusive recommendation that can be made for one type of intervention over the other. Interventions that appear to be most likely to reduce positive outcomes incorporate multimodal group and peer components. But there's many of these interventions here that have been shown to be of some benefit in some people in certain circumstances, including things like animal-assisted interventions. So getting a pet can be really great for some people. Also looking at the gray literature on promising practices. So bottom right here, practice recommendations highlight the following approaches. So patient-centered care, tailor-made to each individual, collaborative health and social care, and social prescribing certainly supports that. Tailored services for diverse populations, and the use of technology, of course, in certain circumstances. And, I think that helped all of us kind of survive the pandemic. There are quite a variety of screening and assessment tools out there. Most of them have been used in research rather than clinical practice, but there's about 15 scales we identified Some are short, some are long. 10 of them have been validated in older adult populations. So, Valtora has developed this diagram that sort of outlines all of the different scales and where they fit in terms of degree of subjectivity, as well as structure and function of the scales. This is a popular one. It's a 3-item loneliness scale. How often do you feel you lack companionship? How often do you feel left out? How often do you feel isolated? Very simple scale. Interesting. It's a loneliness scale, but it doesn't ask if you feel lonely. Isn't that interesting based on what From Reichman said? The Berkman-Sim Social Network Index. Some people like this. Some great questions in here. Not just about, the actual number of relationships you have or the description of them, but is there someone available to you whom you can count on to listen when you need to talk, or who can give you good advice, or who shows you love and affection? So it's got some really great questions in it. Not a great deal around patient experience studies, and some of the barriers identified include difficulties locating and accessing appropriate services, lack of personally meaningful and culturally appropriate intervention activities. And overall, looking at the literature, these are some of our challenges in creating the guidelines. So with interventions, were they looking at social isolation or loneliness or both? Because they are different concepts, so that's important for us to figure out. As always, challenge with methodological inconsistencies and variabilities in approaches to research. Most importantly, a lack of research regarding the impact on diverse populations of older adults, and this is a real challenge for us in creating the guidelines. So there's just not a lot of research. There's a little bit here and there, but not a lot. And then again, a few patient experience studies, which is one reason why we're doing this survey of older adults right now. There are risk factors, of course, listed here. None of these would be a surprise to you. Starting right at the top, of course, living alone and having impaired mobility, recent major life transitions, low income, being a caregiver, psychological and cognitive vulnerabilities like depression, living in a rural location, community issues, size of network, speaking a language other than English, belonging to a minority group, all risk factors. So there's a lot there, right? And then there are triggers or more precipitants, perhaps, of increased isolation. So, for example, of course, losing a spouse or close friends, and so on, and changes in roles. So in an individual, I think we have to look at the risk factors and then recent triggers, what's actually going on in their lives. That will help us to help them make changes. So yeah, who is responsible for making changes in this area? And this chart is quite interesting because it would suggest that you can approach this from an individual perspective, through people themselves making changes, communities, or society as a whole. So in the blue group in the middle there, you've got families and friends, mental health practitioners, family doctors, local groups, voluntary organizations. And then at the bottom, governments, health authorities, funding bodies, and so on. And it is fascinating that I think right now in Canada, there are many groups at different levels addressing this issue, and there have been many supported projects from government, but there is no campaign or national campaign in this area. So it's great that many groups are addressing this, and for example, the social prescribing movement that we talked about earlier, and was talked about yesterday, that's really picking up significant momentum at the moment. I think as clinicians, so we're sort of in the middle there, we can address this both individually, with our patients and clients, and we can make changes in terms of our connectivity with other health professionals. And I think one of the strong recommendations here is the connection between the health provider world and the social service provider world, which are sometimes very connected, but often not. And so I think this is worth thinking about when we think about all the possible approaches. Obviously, our guidelines are designed for healthcare providers and social service providers. So that's the scope. It's a clinical guideline. But I think addressing this on the larger level is also going to be important. So our recommendations may have may go beyond, to some degree, go beyond the clinical, and we may make some other recommendations that are broader. This is from a chapter in that book that I put up earlier, a recent book from American Psychiatric Press by Dilip Jesti and colleagues. This is a chapter by Van Orden and Conwell. And this is an interesting diagram because it suggests that there are many contributors, like it could be a physical illness, mental illness, social stressors, functional impairment, or many of these coming together, but it could be that our interventions should reflect, again, which of these are driving the problem. And I think that's an interesting way to think about it. So coming back to Holt-Lundstad and Prisonotto, the recent article in the New England Journal of Medicine. This is a very simple framework that they came up with that I think is helpful, the EAR framework, so educate, assess, and respond. And so they're saying that we need to educate people about the importance of social connection and the association with illness and death even. And so encouraging people because it's good for everyone's health to have better connections. And the social connections help patients maintain their health, manage existing medical conditions, and adhere to medical regimens. Interesting. So then they say it's important for us to, of course, assess. So I think screening and assessment is really important. That'll be part of our guideline, of course. And they encourage us to document this in the health record. So it should be something that we know with each of our patients, our clients, that what is their level of social support? What is their social map? And who can they turn to when they need support or in an emergency? And they suggest using validated measures. Like I mentioned, there are many screening tools, but in clinical practice, probably the most important thing is that we actually ask about loneliness and how someone perceives their level of social connectedness. So it doesn't have to be, I think, a screening tool, but we should ask about it at the very least. And then responding with a whole variety, potential of individualized interventions. Again, I would say one of the important things is to really understand what is driving the loneliness or social isolation. And if there are many factors coming together, then which ones are modifiable? So we may think of very practical things like hearing. What if someone just has very poor hearing and is reluctant to get hearing aids? That could be modifiable for sure. Well, I just looked at the CBC this morning. This is this morning this is their top article on CBC, the CBC website. It says here, doctors are slammed with non-medical cases. Some say social prescribing could ease the burden. And a shift from what's the matter with you to what matters to you. And one of the images in that article is a prescription by a well-known family doctor, Dr. Gorfinkel, who's written a prescription here for the puppy of choice with walks twice daily and lots of love. I think she put this up on Twitter and had thousands and thousands of tweets and retweets. Finally, then, we want to help our patients, and for some people, we're going to encourage them to change, to get out, to connect more, to exercise more, and This is a great cartoon because it says, who wants change? Everyone wants change, right? Who wants to change? Oh, people are not so enthusiastic about changing, right? And if you're not familiar with the Fountain of Health, this is a Canadian program that originated in Nova Scotia with Kerry Lee Cassidy and colleagues. It's a fantastic program helping clinicians to help their patients make changes. And you'll see social activity is one of 5 areas that the Fountain of Health supports. But this is a great website, found the www.fountainofhealth.ca. It has great resources around how we can help our patients make positive changes in their lives. And finally, back to the world, the WHO, who say that the things that we need to do are to create a coalition to increase political commitment, improve research and evidence for what actually works, and then scale up effective interventions. This is my email address. If you have thoughts, ideas, or anything related to these guidelines, or want to contribute in any way, love to hear from you. That's my email address. Betty Watson-Borg is our project manager. That's her email. And this is, again, the website of ccsmh.ca. Please join us for free.
Right, great. Thank you very much again, David. That was a wonderful talk. We appreciate it. And by all means, feel free to contact David. Thank you, sir.
Thanks so much.